Well, thank you for joining me today for episode number 6 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. So today I'm going to shoot the breeze with one of those people who can talk about just about any topic in healthcare thoughtfully and intelligently, and that is Dr. John Schumann. John's an internist. He hosts an NPR segment in Oklahoma. And he also happens to be the president of the University of Oklahoma-Tulsa campus, and we'll hear a little bit about how a doctor ended up in that role shortly. So today I'm going to talk with John about how the University of Oklahoma has handled the COVID pandemic, what to do when you as a patient disagree with your doctor, and just about everything else that is wrong with U.S. healthcare. If you do like what you hear today, please search for and subscribe to the Healthy Skeptic MD podcast, wherever it is that you listen to podcasts. Please also search and subscribe for my YouTube channel, also Healthy Skeptic MD, and follow me on Instagram. And if you do like what you hear, please do consider leaving a review. It really helps get the word out about the Healthy Skeptic MD. Okay, before we jump into our interview with John, let me go over the health news of the week. So first, a lot has been said already about President Trump's COVID diagnosis, and I certainly don't mean to rehash it all today, but I do think there's an important couple lessons that align with Healthy Skeptic MD principles. So many have said that President Trump has received VIP care. In fact, his personal physician said, "This is the president, and I don't want to hold anything back." Now, I think that's a sentiment that I and many others understand. I certainly don't envy the role that the president's physician is in right now, but I would push back a little bit, and I'm not actually sure that the president has gotten better care than the standard. In some ways, it may even be worse. So far, for his treatment, the president has received zinc, melatonin, Pepsid, the Regeneron antibody cocktail, remdesivir, and the steroid medication dexamethasone. Now, each of these medications in isolation has its own set of side effects, but when you put them all together, there can be all sorts of interactions. The other thing that's worth noting is that this Regeneron antibody cocktail has actually only been used in a few hundred people in experimental settings in trials. I'm not sure I would want to use a medication like that in the president of the United States that's only been used in a few hundred people. And then with respect to the steroid dexamethasone, many of us think of these as benign medications, but as I'm going to talk about in a second, they actually can have some downsides. And this medication has been shown to be effective in people with really severe advanced COVID disease that's not responded to the common measures and treatments, but it's actually been, there's been some concerns about harm in people with earlier moderate disease. So overall, I'm not sure that the president did actually get the best VIP care, as some might say. I think another important lesson from President Trump's illness is about testing. So many have argued that, testing is this panacea that's going to get us out of the pandemic. And I actually think it's exactly because President Trump and many others at that famous Rose Garden event where he seems to have been infected, because they had received tests that were negative, they had a false sense of security and were maybe closer with others and not using masks as others might have. So, I really do believe in testing. I think there's a strategic important role for those with symptoms, but I think until a vaccine gets available, it's really going to be the simple measures, masks, and as Dr. David Katz said, the simple things we can do to protect high-risk, frail people with chronic complications that's going to get us, that's going to protect the most people. So I also want to mention one other non-COVID study today, also related to steroids. It's an analysis of the Annals of Internal Medicine, and it talks about the use of steroids for those simple things like colds and back pain and rashes, those little annoyances. In medicine, we call steroids the feel-good medications because they often make us feel better quickly. But we often forget that they do have, even in the short-term use, side effects such as driving up your blood sugar levels and triggering mental health complications. And this new analysis in the Annals of Internal Medicine highlights a couple additional side effects. So it found that there was, from a short course of steroids within the next month, a doubling in the risk of gastrointestinal bleeding, sepsis, and heart failure. And incidentally, there was another article in one of the JAMA Journals, not about this specific study, but an editorial that said that even short-term use of steroids carries the potential for troubling and sometimes dire adverse effects. Consumers of healthcare, the public, may be allured by the prospect of a quick fix that they disregard any ramifications for their overall well-being. So I think the lesson here is that steroids can indeed make us feel better. There's important uses for them, but we do not want to reach for them for every ache and pain and sore throat that we experience. And this is probably a lesson I should heed to in my practice. So with that, let's jump to our interview with Dr. Schumann. Okay, well, I'd like now to welcome to our show Dr. John Schumann. So John has a really interesting background. He is an internist, and he also happens to be the president of the University of Oklahoma-Tulsa campus. John is a graduate of Yale University. He completed his residency training at the same place I did, the Cambridge Health Alliance. And maybe we'll get a chance to talk about the Cambridge Health Alliance because it's one of those places that gives me hope that it is possible to practice patient-centric medicine in our crazy healthcare system. It's a really great place. John has done work on just about everything imaginable in healthcare, focusing on human rights, medical ethics, and profit motives in healthcare. Well, John, the first question I have to ask you, are your students back on campus now with COVID?
The answer is mixed. We have a few students who are on campus. About 25% of our classes are happening in person. We have a universal masking requirement on all of our campuses, so everyone's wearing a mask anytime they're not, as I am, closed door in my office where I have, space. And then all of the in-person classes have to be under 40 people in the classroom. Anything above 40 is moved online, and then they have to have adequate physical distancing in those classes. Basically, our health professional classes are happening in person where there are rotations. You can imagine third and fourth year medical students or PA students or nursing students who are doing rotations in hospital or in clinics. They're going in person. Some of our allied health, that's physical and occupational therapy, where they have laboratories or simulations, those are happening in person. But the vast majority of our classes are happening online.
Well, it certainly is a simpler situation. Here at the University of Southern California, we do have a lot of residential students, and it's the dorms where we really worry about those outbreaks happening. But it's great that you've been able to at least keep a lot of your university activities open, and it probably helps having a physician as a president in this particular circumstance. So, John, you and I have had a number of conversations over the years, and I think we share a common concern about the U.S. healthcare system. What are the barriers that interfere with good care and patients getting what they need in our current healthcare system?
As I see it, the biggest problem is that we continue our single biggest driver or point of entry to the healthcare system is health insurance, and that is usually through employer-sponsored health insurance. And while that's great if you're employed, and it's great if you have that as a benefit, it really creates a barrier for all of those that are outside of the employment insurance system. And of course, there's many people that are employed that don't get insurance as a benefit, typically lower wage workers, and there are many people for whom they have it as an option but can't afford it. The other obstacles are the incredibly Byzantine structures that we've established in our insurance-centered system, which are, co-insurance, essentially co-pays and deductibles that act as barriers to people seeking care. And they wind up discouraging people from doing so. And so we wind up with a very, much like our economy, a very unequal access to the systems. And so we wind up, treating things once they become much more rampant or advanced, particularly things you think of like colon cancer or breast cancer, those kinds of things.
Yeah, so it's always struck me that there's a real paradox. On one hand, we have all these barriers that get in the way of people getting the simple things that they really need. But one of the themes of the Healthy Skeptic MD podcast is that we also have a problem of overuse of medical services. And I guess I'll just ask you, do you think we overuse healthcare services?
Well, I think the empiric evidence points to yes, because we as a nation spend, people often quote the number $3.5 trillion per year, and it's almost 20% of our gross domestic product is spent on healthcare goods and services. So by that measure in aggregate, we definitely overspend and arguably overuse. But then many commentators would suggest that our overspending is that there's inflation or that there's a huge amount of waste, and so people like institutions like the National Academies of Medicine have said that up to a third of that $3.5 trillion spend is wasteful or redundant, and so we're not getting actual value for that. So the question of are people getting too many services, I think the answer is in some cases yes, definitely, but in probably more cases we're under utilizing services. And so it's that huge imbalance where some are overusing and probably more are underusing or underutilizing or not having a way to really access the system or get necessary care.
So one thing, John, that you've written about, you've written about many things, but the thing that you've written about that's really caught my attention is patients who leave the hospital or leave the medical system against medical advice, essentially when patients don't follow exactly what we, the doctor, tell them. So can you just begin by explaining what does it mean and why might a patient leave a hospital against medical advice?
Essentially, the idea is when a patient is hospitalized, they're there on a voluntary basis. And it is amazing what people put up with in terms of our medical regimen as far as testing and treatment and living in a hospital, spending time in a hospital, whether it's several days or one night for surgical operations, or presumably they're doing that of their own free will and they've given consent. But in our world, in internal medicine, people often come in because they have an exacerbation of a chronic condition or an acute condition that leads them to really not be able to care for themselves, and ultimately to face serious morbidity or death. And so they come to the hospital, often through an emergency department nowadays, but still sometimes through a direct admission. And so we do our best to diagnose and treat their illness. Now, all kinds of pressure comes to bear to get patients out of the hospital. We definitely don't want to keep them in there any longer than they need be. And in fact, that health insurance system that I talked to has specific recommendations or guidelines that they're going to threaten the hospital with non-payment if a patient stays longer than a certain diagnosis merits. That's known as the DRG, or diagnosis related group system. But in any event, a patient has every right to say, the heck with this, I'm out of here. I hate the food. You keep sticking me with needles. I want to go outside and smoke. I want to do a lot of things that, have control over my destiny. And right now I've surrendered a lot of control and I'm very frustrated. So I'm going to leave. And the whole convention of AMA was, I think, dreamt up probably by lawyers. The idea being that we want a patient to actually sign a physical piece of paper, a document that says they attest and understand that they're signing out against the medical advice of the healthcare team, of the doctor that's treating them, and understanding that the responsibility may fall on them. And what's too bad about that is that we do it in a punitive way, I think, very often, not always, but sometimes there's a small sense of relief, because frequently patients that sign out against medical advice are agitated because of the fact that they may be withdrawing from a substance, or they may want to go outside and smoke, or they may want to eat the kind of food that they choose to eat rather than what we serve them in the hospital. And so they're sometimes willing to sign the form and say, kind of, here's my signature, out the heck with you, I'm out of here. And sometimes, of course, they see that as a total charade, and they, for what it is, and they just bolt right out of the hospital. And that's really what against medical advice is. The way I came to this literature was actually when I was working at the University of Chicago. A medical student came to me and said, she didn't phrase it this way, but ultimately it was a little bit of moral distress. She saw the resident she was working with sort of browbeat a patient into staying, even though the patient was frightened by the idea of a cardiac catheterization. And the patient said, I don't want to do this procedure and I want to leave. And the resident that the med student was working with said, well, here's the thing. If you leave and you don't submit to this test, you're going to become financially responsible for the cost of this hospitalization. And you know what? The patient wound up staying, having the procedure. Fortunately, everything went okay. The patient did fine, and the patient wound up going home. And I don't even remember if the patient was found to have a cardiac lesion or if it was remedied. But that medical student came to me as a small group advisor and said, this really upset me. And in fact, I had never heard that, but it was a pervasive medical urban legend that if you sign out against medical advice, you become financially responsible for the cost of the hospitalization. It wasn't true then, it's not true now, and yet it is still a pervasive medical urban legend.
Well, that story actually triggers a memory I have from my training when I had a patient who was admitted to the hospital with very out of control blood pressure, and the cardiologist came in and had some recommendations and wanted to increase the blood pressure medications, and the blood pressure still wasn't at adequate control. And the patient was getting antsier and antsier, and he had some family obligations he wanted to handle. And basically the cardiologist came in and said, "You cannot leave. We need to get your blood pressure under control." And he told me after the cardiologist left, "I really have to get out of here." And I said, "All right, well, let me see you in clinic and we'll do what we can do." And the patient followed up, and actually his blood pressure was much better when he was out of the hospital, maybe because he was not getting poked with needles and woken up by nurses all the time. And we were able to very nicely titrate his blood pressure medications up as an outpatient. And, it was the first time that it occurred to me that maybe the doctor's advice isn't always the right advice, even if they are a specialist in whatever topic that would be. But we doctors do get, for lack of a better term, bent out of shape when patients don't follow exactly what we say. And, I'm guilty of this as guilty of this as anybody else. Why is it that we doctors get so bothered when patients don't do exactly as we say?
Well, as you mentioned, it's the ego thing is a huge part of it. So we are ostensibly, most of us are good apples. We're trying to do the best we can. We're trying to do what seems medically right. And patients come to us and ask for our help, and we do the best that we can. So when they disagree with us, and they may not disagree with us on the merits, but they simply may have a need that has to be fulfilled. And in thinking about this, I talked a little bit about tobacco abuse, but it could be untreated or undertreated chemical dependency, so alcohol abuse or certain drug abuse. Those are major reasons why people sign out against medical advice. But there are also social determinants, and I know you've talked to other guests on the program about social determinants. It could be a rent payment, or very importantly, it could be a job. Someone might lose their employment because they don't have paid time off or the ability to essentially get treated for their illness. The threat of losing their job is so strong and so severe as to cause economic hardship that they want to leave the hospital. So the reason of why they want to leave may have nothing to do with the actual medical knowledge or medical care we're providing, but it does affect our ego. We think, oh, why aren't they listening to my advice? That's one thing. And I'd say the second big reason is the fear of liability. So if a patient, the catastrophe scenario is they either walk out or they sign out against medical advice and walk out of the hospital, and then they drop dead from the heart attack or the stroke or what have you, whatever we're treating them for, or even what we're not treating them for. And so the perceived potential guilt of that, just the emotional guilt, but of course the negligence guilt. I think that the liability fear is overblown. But again, hospital lawyers have written those documents that we do ask people to sign. Whether they have any legal teeth or not, is for lawyers and the judicial system to decide.
Yeah, I think that's right. Some of our listeners may have read the book, The Spirit Catches You and You Fall Down, and it highlights the tension between two different approaches, where there's one set of doctors who want to treat this child who has epilepsy according to the textbook, and if the family doesn't follow exactly the protocol, they want nothing to do with the patient. And then there's a more lenient approach where the doctor is letting the family not necessarily follow all the protocols and be a little lenient with taking the medication. And I remember having a lot of discussions about that book as a medical student, and people were really torn. But I actually on that one really sided with the approach of working with the family where they were. And healthcare is as much an art as it is a science, and we're here to serve patients and help them achieve whatever their goals are. So I can obviously see both sides of the coin on that one, but certainly my philosophy is one much more about patient autonomy, which is why the work that you've done to highlight that patients may actually have good reason for leaving or not following the orders of the doctor exactly as they're written. That's always resonated with me. Could I just ask as a final question on this topic, is there ever an appropriate time when a patient should not follow their doctor's advice? Is that ever appropriate to do?
I mean, I think the simple answer to that is yes. I think too often we present things, present options in a skewed manner. That is, we will often lead with the procedure or the treatment regimen that we ideally think is efficacious, that's liable to help the patient or treat the condition. But instead of presenting them as perhaps equal or even unequal options, but what's left unsaid a high percentage of the time is you could choose to do none of these things and you could leave the hospital. But I should also point out that one thing medical ethics training taught me is that autonomy is all about the right to make what we might consider bad decisions. But if someone is of sound mind and, might make a medical decision that we don't agree with, but they have that right.
Well, I want to shift topics a little bit to the topic of the season, which is COVID. And let me just start by asking, how are rates of COVID in Oklahoma right now?
Rates are high. Our test positivity rate is hovering around 10%. I can't give you an exact quote at the moment. We get sort of a weekly update from our panel of local health experts. It's for some reason always on Wednesdays now. But we get probably twice or 3 times a week briefings from the executive director of our health department. But we are about third highest in rate right now. So we have it's
in the country.
Yeah. But that's on a percentage basis. We're actually a pretty small state in terms of population. There's only 4 million people that live in Oklahoma.
I think I saw in the national news there was actually, I think it was Oklahoma State, the students, there was a small spike on campus there. Am I remembering that correctly?
You are? Yeah, there have been spikes at both Oklahoma State and my own University of Oklahoma, particularly in the Greek system, fraternities and sororities. They came back on campus and didn't have strict protocols. Often the reason cited is that they are not owned by the university, those houses, and so they're sort of independent of the university. And so I know I can't speak to OSU, but in the OU case, like our Dean of Student Affairs had to really work with the leadership of the Hellenic Society to really get them to try to adhere. I don't mean to criticize them. I think they had some national standards, but I think might have had trouble implementing them on a local level. And I do think that they've done a better job. And I think with the universal mask mandates on campus, at least, we've managed to control things. I not totally control them, but control them a lot better.
Yeah, well, certainly here at USC, that's also where the outbreaks have been within the Greek system. Well, I know you don't have a crystal ball, but I thought it's worth asking anyway. What do you think this pandemic has in store for us over the next few months?
Everything I read and everything I follow leads me to believe that it's going to continue in this very slow, painful way where we're just going to continue to have small embers that flare up in different states. If you want to call them second waves, if you want to call them third waves, we don't, as has been stated on your program and everywhere else, the lack of a national policy, of a coordinated effort, of state policy in my state, we have way too much of a patchwork that has led to individual localities and institutions, businesses, or in our case, universities, implementing their own rules and regulations. And it's just been, frankly, a nightmare. I mean, it's just been chaos. And so I just, shy of a major shift in national direction, I don't see this getting any better. And yes, I am hopeful of a vaccine, but any prediction that we're going to have a vaccine in calendar year 2020, I think, is hopelessly naive. And even if we get one in, say, first quarter or second quarter 2021, until we get it scaled up and distributed and figure out who's going to get it. So I just think this school year, in many ways, is a lost cause. Now, that said, I mean, some people are very capable at the remote learning, both the instructional side and the student side. But I think there is a tremendous challenge for, especially like young children who, staring, it makes my heart hurt to think of, 5-year-olds or below staring at screens all day.
From your vantage point as a college president, I'm sure you face a lot of pressure to reopen schools before there is a vaccine. I agree with your assessment that it's very unlikely that there could be something that's safe, effective, and widely distributed in the United States before the middle part of 2021. Before we get to that state, is there a way that we could start reopening some campuses in some sort of normal fashion through masks and social distancing, or is that just a pipe dream?
No, I think we can absolutely do it. I just think we have to have better systems in place to figure out, and I learned a ton from your interview with Dr. David Katz, who we need to risk stratify better. And we know, we've known pretty much all along, but we have failed to implement sound solutions for protecting the most vulnerable, be they the aged and or those with the comorbidities. The infection and morbidity and mortality rate ultimately is so much higher for those at the age and comorbidity extreme, whereas you have this vast swath of society for whom COVID-19 or novel coronavirus, or however you want to phrase it, the illness is manageable. But to answer your question, yes, I think we can safely do it, but we've got to have better testing, tracing regimens, and we've got to have more clarity around how we do it.
Well, it was you mentioned the David Katz interview, and he criticized the United States for not doing exactly what you're saying, sheltering the frail, elderly populations, those with chronic comorbidities. And right after that interview with him, I actually had a patient with a very advanced heart disease. He was actually on the wait list for a heart transplant. And he was working as a security guard, and he was actually the person who checks the temperatures of the people coming in to make sure that they don't have a fever. I couldn't think of a worse job for someone like that to have. And then on the other hand, we have these young, healthy people who are out of work, desperate for work. And it just strikes me that we could figure out a way to be smarter, more creative, and get the people who are safer and less likely to have a complication be the ones on the front lines. I mean, you even see it in the grocery stores. It's the geriatric patients that are bagging the groceries, and it just doesn't make any sense. Well, John, I so appreciate your joining today. It was really a breath of fresh air to hear your perspective on how to make our healthcare system better. If you like what you heard today, we're the Healthy Skeptic MD. Subscribe on YouTube. You can search for Healthy Skeptic MD wherever you listen to podcasts. Thanks for joining, and we'll be back again next week. Thanks.